Just give me a few minutes. I got to put it on the internet. Okay, we're live on YouTube. We're at 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, this is Dr. John Bennett from Neurosurgical TV. This is the French Neurosurgery Grand Rounds, and these are the last English words you're going to hear until it's over. And we'll start now with Adrian Carl. He's a neurosurgeon currently in Normandy, France. Welcome, Adrian. It's all yours.
Hi, John. Bonsoir, John. Bonsoir, tout le monde. Bonsoir, Saïd. Je te laisse présenter notre invité de ce soir pour notre 32e webinaire francophone déjà. Donc, il ne sera pas vraiment francophone ce soir, mais...
Très bien, Adrien. Notre invité ce soir est le professeur Ibrahim Sbeih, l'un des plus renommés neurochirurgiens du Moyen-Orient et l'un des talentueux chirurgiens que je suis régulièrement. Et je vais faire une petite introduction. Can I share my screen, please? This is a presentation of our department of neurosurgery in Réunion Island. With this is the do you see my slide? Yes. Okay. This is my hospital, and there is my colleague. I am the oldest neurosurgeon here in Réunion Island from about 27 years. And actually, we have Dr. Ferpel, who was resident in our department, and now he's head of Department of Neurosurgery. Dr. Guillaume Lemestre, who's a neurosurgeon. Caldo Campes, Paloma Campes. Tanya, like the assistant, our assistant, and this is our OR. This is our team in the operating room, and I'm glad to work with them. Réunion Island, it's this small point that we see here near Madagascar. It's our overseas department, and he's about it's about 11 hours by plane to Paris. It's a beautiful island. And in this region, we have Réunion Island, it's a French department, which Tourmaline is a French island, and here the second department, the last department French department overseas, Mayotte. And Mayotte historically is an island from Grand Comore. But this choice to still French territory. So we this region, in this region, there are many people that come from other island or from Africa by boats, by night. So with a medical problem, and they are transferred to our department by plane with medical assistance in serious problem. Réunion Island, it's a small island, but it's rich because it's multicultural and multicultural. Each population respect the others, and we what we call the living together, le savoir-vivre in French. So we and the island is a beautiful island with a mountain, with a beach, but the mountain is very beautiful. We have a spectacle with the volcano. It's a great spectacle, that, as we say here, and beautiful how this is the home of Abdelkrim Khattabi. He was Moroccan resistance against Spanish people, and he was murdered here in Réunion Island in 1924, I think, or 5. So, Professor Ibrahim Sbeih, welcome, and we are glad to have you with us tonight.
Thank you very much indeed. Can I just share my screen?
Yes, excuse me, yes.
Let's start.
Okay, perfect.
Can you hear me?
Yes,
Yes.
Can you see my slides?
yes, perfect.
Well, I would say bonsoir for all my French colleagues. Time in Amman now is 8 o'clock. I believe it's 6 o'clock in Paris. It's my honor and pleasure to be invited to the French Society speaking members. My name is Ibrahim Sbeih. I'm speaking to you from Amman, Jordan, and this is pictures of the Farah Medical Campus where I'm working. My presentation today would be about the radical accession of craniopharyngiomas. This is me by evolution. This is my family, my wife, 3 girls and 1 boy. And my elder daughter is a neurosurgeon. She is the 3rd female neurosurgeon in Jordan. And she trained with me and with Professor Majid Sami in Germany. Jordan, for those who don't know Jordan is a Middle East country bordered by Syria, Israel, Egypt, Saudi Arabia. And we have 2 seas, as you can see in the map. Here we have the Dead Sea, and here we have the Red Sea. So Jordan has 2 seas, the Dead Sea and the Red Sea. The Red Sea of Aqaba is just opposite to the port city of Eilat in Israel. This is my daughter snorkeling in the waters of Aqaba. And we have the Dead Sea, which is the lowest point on Earth. It says here 420 meters. That was a few years back. Now it is about 450 meters below sea level. This is the lowest point on Earth. The Dead Sea is void of any marine life, and you just can float on the surface of the water. reading your newspaper like this. And this is the famous mud bath of the Dead Sea, full of touristic sites. Near the Dead Sea is the baptism site, which is the recognized site by the whole world of the baptism on the River Jordan. It's a UNESCO World Heritage Site in Jordan. The Basilica Church of Trinity is built there, and baptism rituals are done there at the River Jordan. This is Pope visiting us, and he made his steps on the marble steps in the site of baptism. Nearby also is Mount Nebo, a famous site. Also Pope visited us there. And nearby is the city of Madaba, which is called the city of mosaic maps, where the world maps were done by using mosaics. Also in Jordan we have Jarash, which is lots of Roman amphitheaters and Roman antiques. It is second only to Roma. So the place to find Roman antiques and theaters is in Jordan, just second to Roma. Lots of festivals are carried out each year in Jarash, drawing lots of people from around in the Middle East and the world. Every country in the world comes to Jordan for that summertime Jarash festival. And of course, the jewel of the crown is Petra, one of the world wonders. This is how you get into Petra, through this slit between rocks, which is about 1 kilometer. Gradually you come and at the end of the slit, and then you can come across the Petra. And on the way to Petra, you have to go through Wadi Rum, which is just like Mars terrain, as if you are in the outer space, and lots of movies have been done there. The last of them was Aladdin, and of course Lawrence of Arabia. People think of Jordan as a desert. It is not. Part of it is a desert, but part of it is mountainous with lots of countryside scenes. And this is the capital of Amman, a very ancient city. It's called Philadelphia in the past, and it's again full of the amphitheaters of Roman era. This is my house in Amman in summertime, and this is in wintertime. So a lot of people don't know that we have snow every winter. In fact, we have very heavy rain nowadays. Next month we will have the same snow like this. And this is the Black Iris symbol of Jordan. So I just presented my country for you, and I have to present the neurosurgery in Jordan. Neurosurgery started in Jordan back in the early 60s. This is the first neurosurgeon of Jordan, Anton Tarazi. He was born in Palestine. Here he is in the school of Tarasanta in Jerusalem. He was actually part of the music band there in Jerusalem. In 1948, Palestine was partitioned into two states, a Jewish state and an Arab state, and war erupted. So this man, Anton Tarazi, had to leave Palestine and go to Beirut, where he attended the American University of Beirut back in the 1952. He graduated from there and went to have a specialization in Montreal, Canada, with giants like Cohn, Elvidge, Rasmussen, and Penfield. He excelled, and his superiors loved him, and he really had a very good reputation there. And then he came back to Palestine, to Jerusalem in 1961, where he opened the first neurosurgical unit in Augusta Victoria Hospital in Jerusalem. This is him treating patients there in the early 60s. And you may not believe this, but in 1966, he hosted the first Middle East Neurosurgical Congress in Jerusalem. He died in 1999, and he just finished his surgery that particular day. One of his fellows and people who trained under him was John Jane Sr. from Charlottesville, Virginia. He wrote about how affected he was by his mentor, Dr. Tarazi, And he says, I have remained grateful for Dr. Tarazi's dedication to teaching, and to his influence has continued throughout my career. He said, Anton Tarazi is the first Palestinian neurosurgeon and the first neurosurgeon in Jordan, a neurosurgeon of 2 countries. That was published in World of Neurosurgery. You may remember that in 1967, Christian Bernard of South Africa did his first cardiac transplant. It was something, it was an explosion in the medical field. 3 years later, here in Jordan, David Hanania of Jordan, a cardiac surgeon, performed the first open heart surgery. We are proud that Jordan is a medical hub, surgical hub for the Middle East, and the revenues from the medical tourism in Jordan is 1.5 to 2 billion per year. This is the first heart transplant also in Jordan back in 1985 in the Cardiac Institute in Amman, making Jordan country number 8 in doing that surgery. Also, Jordan had the first IVF baby back in 1986, earlier than many, many countries of the world. First CT scan in Jordan was in 1978, that is 2 years after it was invented in England by Hounsfield engineer. Interventional radiology is very much in practice in Jordan, very, very advanced. We have all sorts of equipments and medical equipments. We do most of the surgeries of the posterior fossa and the sitting position, and we have never lost a patient during that. A microscopic surgery is in abundance. Cranial nerves monitoring and everything you can think of is there. Robotic surgery has been there for about 15, 16 years, and I remember going to train for that surgery in Salpêtrière hospital in Paris. I've done the first gamma knife treatment for vestibular schwannoma back in 1996, making Jordan the 13th country of the world acquiring gamma knife. We had the guts to put a bidding to host the World Federation back in 2013. We came only second to South Korea, beating Japan, China, Indonesia, and Malaysia, and others. I've established the cadaveric microanatomy laboratory back in Amman in Jordan about 7 years ago. And we have held so many courses teaching people how to operate, the approaches, surgical approaches coming from all over the Middle East, the candidates. And we held lots of courses there. This is Vinko Dollens and Ali Kresh doing some of those courses. The first Jordanian Neuroscience Society was established in 1983 with only these people around. Now we are more than 104 neurosurgeons in Jordan in many disciplines. So there is not a single discipline of neurosurgery that we don't cover. Cerebrovascular, spinal, trauma, peripheral nerves, radiology, radiotherapy, habilitation, ophthalmology, facial maxillary surgery, pediatrics, skull base, endoscopy, functional, you name it, it is there, and we are well trained in it, and we are head and shoulders above many others. Lots of giants of neurosurgery visited Jordan. I remember this visit by Charles Drake back in 1992, was his companion. Lindsay Simon, the president of the World Federation, visited us in Jordan. Professor Yazarjid came here many, many times. Here, the picture is with me and him and his wife, my wife, and here with his wife. Professor Broughton also was a frequent visitor in Jordan. He's a closer friend of mine. Late Professor Broughton has a great effect on my life and on my career. He's a great man. I feel sorry for his loss. Professor Spetzler also here. We are members of the World Academy of Neurosurgery. Here we are in Vienna. Here is Professor Spetzler in my house meeting King Abdullah. Also, Professor Takeshi Kawase with his wife being also frequent members of Jordan, his wife and my wife and him visiting us in Jordan. Roberto Heroes, Oliveira, Hermesemini, D'Souza, Edward Luz, Shaker, Osiko, Majid Sami, Al-Mifti, Marcos, Konovalov, all of them visited Jordan. And when I speak about French neurosurgery, we in Jordan look at the French neurosciences with respect and admiration. Who can forget the role Charles Labey performed in the past, discovering the vein of Labey, or Trollard discovering the vein of Trollard, or Pierre-Paul Rocca, who discovered the Broca's area. And I keep telling my neurosurgical residents here that if you go to Paris, visit Eiffel Tower, you will find his name is inscripted there on the side of the Eiffel Tower. Not only those giants, but Professor Jacques Mouret was part of our success here in Jordan in interventional radiology. This is him visiting us, and this is the first coiling of an aneurysm in Jordan back in 1999. Professor Mark Sandow also being part of the scene in Amman, Jordan, and late Professor Bernard Jord is a closer friend of Jordan and myself. And Professor Ben Abid, whom I visited in his unit in Grenoble. And also a friend of mine, a friend of Jordan, is Maurice Shooks, whom him and I were members of the Administrative Council of the World Federation for about more than 20 years. So now back to the lecture, radical accession of craniopharyngiomas. As you know, the pendulum still swings between whether you go for partial resection and give radiotherapy, or you go for radical resection without radiotherapy. I must say from the beginning, I go for radical accession. I don't want recurrences, I don't want many procedures, and I don't want to give radiotherapy. So I know the debate persists, but I have made my mind. I am for a radical resection. You may know or you may not that in many parts of the world, especially the third world countries, the treatment of craniopharyngioma is very simple and very primitive, let me say. They just puncture the cyst. Most of the time they put a Meyer reservoir. Most of the time they do shunts. They do very minimal resection and they give radiation. This is still practiced in the Middle East, it's still practiced in the third world countries, which I'm totally, utterly, grossly against. Not me alone. Look at Edward Luz from Harvard speaking about his expert opinion. He will give you this case history. This was in 2012. He will speak about this 4-year-old boy from Mexico who in 92 had a right shunt, a left shunt, a biopsy and aspiration, a revision of a shunt, then craniotomy with a very partial excision on radiotherapy. 5 years later, another craniotomy for recurrence. 2 years later, another recurrence given gamma knife. 2000 recurrence, he refused surgery and died. This is a common story of craniopharyngoma in many, many parts of the world, even some of the civilized countries of the world. So unfortunately, case history like this is very, very common, and we should fight against this practice. So not me, not Edward Luz, lots of people would go for radical excision. I'm just putting here, I've done my homework and study, putting you the names of the authors who did radical excision through the years. So many, many people, giants and neurosurgeons, who did radical excision of craniopharyngoma. And not only the high percentage of radical excision, 90%, 70%, lowest is 60, but it's 90, 80, and so on percentage of radical excision of gross total resection in big numbers of patients. Even in France also, they went for radical excision and so on. So it is the major line of treatment in the best centers of the world, radical excision of craniopharyngoma. And you would wonder why still people are doing the partial excision and radiotherapy. Let me take you back through the history. 1976, Harold Hoffman, the famous pediatric neurosurgeon of Canada, said that 20 out of 29, he did total removal. Now we are talking about 1976. Only CT scan is available, very little armamentarium of a neurosurgeon is there, yet you can do radical accession back in 1976. Why can't you do it now in 2022? The same thing with Harold Hoffman back in 77. Look at this, a giant craniopharyngioma. He didn't go for a cyst and little biopsy. He went for radical accession, 1977. 1985, Sam al-Mufti published this beautiful paper with lots of drawings and things. Again, CT scan. What does he say? With modern neuroradiology, microsurgical techniques, and endocrinology support, majority of these lesions can be safely removed. That's back in 85. And he's speaking about modern neuroradiology. What about modern neuroradiology 2022? Why can't we do radical accession? And he would say, he would go for total removal of giant craniopharyngiomas, and he would indicate that a gliotic layer usually exists between the tumor and the functioning wall of the hypothalamus. People would speak about, don't touch the hypothalamus, you will destroy the patient. No, you will destroy the patient if you don't do radical accession, because you will leave lots of the tumor there, you will give radiation, lots of procedure, recurrence, shunts, this, that, and the other, and this would end in death. So that is for the best interest of the patient that you go for total removal. Hamad Ghazi Yazarjir back in 90, he published this large series, 144 patients. What does he say? The best long-term control of a craniopharyngioma can be achieved by complete removal of the tumor at the initial presentation. This is the chance of the patient to be cured the first time, not the second time, not the third time. Carmel in humans, 1990, we advocate radical resection as the optional treatment in all patients, young and old, especially in young. Incomplete resection is a virtual guarantee for recurrence within 3 years. Why do you want to do partial resection and then have recurrence? From France, also this paper in 2002, conclusion of that paper, radical surgery gives better outcome of survival, full recovery, and good quality of life for both adults and children. Another paper from Edlows, attempt at radical removal of a tumor should be considered even for recurrence. So you don't only go for radical excision for the primary tumor. If they recur, you also go for radical resection. And the non-surgical options like chemotherapy, radiotherapy, this, that, and another, they should be adjuvant therapy, not the main therapy. Rudolf Farbusch from Erlangen, Germany, radical excision of 94 cases with long-term good social functionality. Again, paper by Rudolf Farbusch, followed 2012, 73 patients, gross total resection in 89%, with complication of 14% and no mortality. This man, Steno, changed our concept of craniopharyngioma with this paper speaking about 3 types of craniopharyngioma, either they are outside the third ventricle, or they are in and out of the ventricle, or totally inside the ventricle. The ones that are really totally inside the ventricle constitute only about 10%. Tomita from Japan, total resection provided the best outcome. Japan, Minamida, not only for primary tumors, but for the recurrence. First surgery, radical. Come back again, radical resection. Third time, radical resection. This is the way to treat craniopharyngioma. It needs people who are interested in craniopharyngioma, who are solid enough to do such surgery. From Argentina, also radical resection of craniopharyngioma. You don't just take a piece of the tumor and send for radiotherapy. Majid Sami, 2006, 65 cases, giants, gross total 64 out of 65. Jose Maria Pascal is another man who also wrote lots of papers on craniopharyngioma, and he changed our concept about this and give us the courage to go and do radical excision. Christian Saint-Rose from France, whom I met several times, the best overall results is achieved with complete resection by experienced craniopharyngioma surgeon. So you need an experienced craniopharyngioma. It is not for the novices. It is not for young neurosurgeons to do. It needs a person who has the experience, who has the guts, who has the courage to give the patients the best chance possible. From China, 2008, Professor Zhang, total tumor resection is feasible with preservation of vital structures with lower recurrences and lower morbidity. So different countries in the world, different authors, giants of neurosurgery, all go for radical accession. Another paper from Jeffrey Wizoff from New York, 2010, efficacy and safety of radical resection. In the hands of surgeons with experience in craniopharyngiomas, we believe that radical resection at presentation, the first time, offers the best chance of disease control. So this is the chance, the first time to go and do radical excision, not the second time, not the third time. Another paper from Stino, the giant of craniopharyngioma from Slovakia, who is a close friend, and I met with him several times. This is very important slide. The final decision about the optimal extent of the tumor should be done during surgery. You cannot say before doing the surgery, I am going for partial resection and radiotherapy because this is good. This is not good. You go in with a state of mind that I want to remove this tumor. Maybe you can, maybe you can't, but you don't decide this unless you go in and do your best. Again, another paper from Manuel Pascal telling us that when the tumor is in the third ventricle, the mammalian bodies will just go around. The tumor will open the way for you, so you will preserve the hypothalamus by doing surgery. You will destroy the hypothalamus if you don't. If you leave that tumor, then you will give radiotherapy. Radiotherapy will destroy the hypothalamus. It will destroy the brain, and you will have extra tumors coming in. From Korea also, this paper, is complete resection in adults feasible? The answer is yes. Complete removal at first surgery provide the best chance for cure. From Japan, Kenji Ohata, my friend, aggressive tumor resection should be the treatment policy. Mortini from Italy, radical resection is associated with the best outcome in terms of survival and recurrence-free survival. From Mayo Clinic, look at this. Mayo Clinic, 2018, maximal surf resection via microsurgery or endoscopy. I'm not fighting here whether endoscopy is better or microsurgery is better. Both are good in the hands of people who know what to do. So maximal resection, whether you do microsurgery or endoscopy, is the best for the patient. Okada from Japan, 2018, 81 patients, radical resection again. From USA, endoscopy, 2019. Again, gross total resection was 86. So we'll not fight whether endoscopy is better or microsurgery is better. When you go in, you go for a kill, you go for a radical resection. So these are some of the papers of endoscopy, World Neurosurgery 2010 from Japan, 70 patients, gross total resection, 80%. Another paper by Snyderman and his group, radical resection using endoscopy. What more evidence do you want? Again, this paper about endoscopy doing radical excision. So let's put an end to this. Radical excision, you go in, you don't decide from the very beginning, you decide I'm going for radical excision, you go in and do your best for radical excision. If you can't, you stop. But don't decide from the very beginning and teach your residents that partial resection and radiotherapy is equal to radical excision, because it is not. Lots of bad practices in our part of the world and in the third world countries, and still in many countries around the world, is to put the shunt up front. This is a crime against humanity, because if you remove the tumor, you may not need a shunt. I don't want a shunt in the head of my boy or girl, of my children. So why should you put one in the heads of others? A shunt can wait. If you go for radical excision, you don't need a shunt. Another bad practice, a very, very bad practice, is upfront insertion of Umayya reservoir, as if Umayya reservoir is the cure. It is not. Umayya is a Pakistani neurosurgeon who trained in the States, and he discovered this method of putting some drugs intrathecally for meningitis, and still we are using this instrument which was invented 1965 in treatment of craniopharyngiomas up to date. This is another crime. It is not a cure. It's nothing. From Mayo Clinic, and this is a vital important point. Mayo Clinic or Mayo Reservoir is palliative. It is not curative. Don't put it. It should never be considered as the first line of treatment. So my personal experience now with the radical accession of craniopharyngiomas between 1990 to 2021. I don't include the ones that I've done in 21. I don't include the ones that I've done in 22, because I think you need time to present those cases. When you say I don't have recurrence, you have at least 2 years of putting these in your series. So the count is 114. It is much more than that because I've done lots of cases in 2021 and 2022. Of course, you would expect that the majority were children, and the age group would go from 2 to 80. The protocol for all my patients that they have very detailed ophthalmological assessment of everything, optic OCT, the visual fields, the fundoscopy, and we use the German chart of assessment of the visual field, combining the visual acuity and the visual field defect. We do sometimes visual evoked potential if we're not sure. And we subject patients for full neurological examination looking for signs and symptoms in my series. This is the adults and these are the children. We found hydrocephalus, hemiparesis, cranial nerves, and even epilepsy. So this is the preoperative neurological examination. And for the visual manifestation, we had people who had vision affected, 49 in children, 34 in adults. Also, I subject my patients for a full psychological assessment, including Karnofsky Performance Scale. Since I started in neurosurgical practice, I go for psychological assessment of every single brain patient with a brain lesion, because I think it's very important. And we subject them for full endocrinological assessment, looking for hypogonadism, hypoadrenalism, how much is the growth hormone, prolactin, and so on. And we also look at the partial hypopituitarism, whether it is partial or total, partial hypo, total hypo, and whether this is associated with the DI, diabetes insipidus, or not. We also look for hypothalamic manifestations like obesity, memory changes, sleep-wake affection, and psychological assessment. The images from my series, which I'm going to show you, are all the cases of mine, my patients. Do CT scan for all the patients to see whether there is any calcification. So in this case, you can see this is a very large tumor, but there's a good piece of very hard calcification. We do brain MRV and brain MRA, and if the need be, we do CT angiography. We do MRI, of course, for all patients, and this is one of the patients showing you that we get these patients in my part of the world as giants. If you ask any neurosurgeon how many craniopharyngiomas he does in his life, people would say about 10, 15, 20. I have 114. Jordan population is only 10 million, but Jordan is a medical hub for the Middle East, and I get these patients from all around countries around Jordan. And when they come in huge size like this. Look at this tumor going there and then going into the posterior fossa. So looking at my cases, 114, they were solid, totally solid in 50 cases, mixed in 52. The worrying part is the size, giant size, more than 4 centimeters is the majority. And I mean giant size. No, this is the craniopharyngiomas that I see, that I dealt with in Jordan. Very giant tumors. I'm showing you in the axial cuts and the sagittal cuts, just to show you that they're real giants. I wish I get small craniopharyngioma. I don't. All of them are giants. Still, I would go for radical accession with these giant ones. This is coronal, showing again tumors and their sizes. So my surgical approach is for those giant craniopharyngiomas. Either I go subfrontal or terional or interhemispheric. I will show you the steps of my surgery for the terional approach. So this is terional approach. This is the left optic nerve, right optic nerve, chiasm, and this is the tumor. Again, here with the terional, you have hidden points. Now, the tumor behind this nerve is not well seen. Also, you cannot detect exact location with a stroke. So there are hidden points with the terional. My favorite approach is the lamina terminalis approach, and I will take you through the steps of my surgery. And we published our work in the Journal of Skull Base Surgery. So this is the craniotomy that I do bicoronal. I cut the superior sagittal sinus at the very most anterior point. This is the most anterior point of the sinus. I cut the forks, so I free both frontal lobes, and I go in between like this, and I preserve the olfactory tracts on both sides. So this is what I do. Olfactory tract here preserved, optic nerve left, optic nerve right, chiasm, and I can see the stroke here. So this is the approach, interhemispheric, lamina terminalis, transbasal approach. So I'll show you different views of lamina terminalis in different surgeries that I've done. This is the lamina terminalis here. And this is the line separating lamina from the optic chiasm and the tracts here. In this case, it's very, very crowded. Only this is seen as lamina terminalis. Here you can see A1, and ACOM. Here, optic nerve, chiasm, lamina terminalis, A1. So when you look at the lamina terminalis here, it can be transparent, it can be totally opaque. So you have to be accustomed to different types of lamina terminalis there. In this patient, it just bulged out, the tumor bulged out through the lamina terminalis. But here I have full control. I don't have any hidden points. I can go before the chiasma, I can go behind the chiasma, I can go right, I can go left, I can see the tenocarotid artery here, I can go between both opticocarotid and so on. So the whole view is for me right, left, and center. I do not have any hidden angles. This tumor is just bulging through the lamina terminalis here. And here you can see that it has infiltrated many parts of the chiasm. Again, here you can see the infiltration of the chiasm, and you can see the stroke. If the stroke is incorporated by a tumor, I do not hesitate a second on taking it out. If it is just attached to the tumor, I try my best to preserve. So this is the view, chiasm, and you can see the infiltration here. This is A1, A2, A1, A2, and ACOM. And when I reach there, I open the lamina in the most avascular area. And then, of course, you get this engine-like fluid. Hooray, hooray, success. No, it is not. Taking the fluid out does not mean anything. It's just delaying things, that's all. So you have to open the lamina properly, get the fluid out, and then do the tumor dissection. You can find a plane of cleavage between the tumor and the chiasm, between the tumor and the hypothalamus, between the tumor and the midbrain, and between the tumor and the vascular structures. So here we are dissecting the tumor, different tumors. You can find a plane of cleavage using micro dissection. Different tumors. It's not one case or the second case. It's a school of thought of trying to remove the tumor out completely. Finding the plane of cleavage here. So, I don't hesitate in using the ultrasonic aspirator because lots of these cases are calcified and they are rock hard, so you need to use the ultrasonic aspirator. You don't get afraid of using it near the optic chiasm because you are in control. It is you who control the aspirator and not the other way around. So using the ultrasonic aspirator in cases of hard calcified lesions, you can actually see the wall of the hypothalamus, the lateral wall and the floor. In this case, I have put a patty here and use it to dissect and find the plane of cleavage here. Here you are actually on the tegment of the midbrain. You can see the mammillary bodies and then the tegment of the midbrain here. So you can actually see the hypothalamus, you can see the midbrain, you can see the liquist, and you can see the basilar artery. As I said, if the stalk is involved by the tumor, I do not hesitate in cutting it out. I don't want the recurrence. I want to decrease the recurrence rate here. So I dissect it. Here we're reaching to the dorsum celli, of course, and from there you can reach to the posterior fossa. If the stalk is not involved, then I try to preserve it here. I could see that the tumor is going into the cella and it is attached to the stalk, so I try to preserve bit by bit. The section, you can actually dissect the tumor attached to the stalk. And then you can get this beautiful view going into the tumor, into the cella, and then you can see the basilar artery, the spinocerebellar artery, the posterior cerebral artery, and it's very evident. It's a beautiful view after the resection. And as I said, you can preserve the vascular structures here, the basilar artery as seen through the lamina terminalis, the liquid membrane, and so on. So this is the final view that you get of preserving the stalk, preserving the olfactory tracts, conservation of the vascular structures as a whole. My results, gross total resection, was very much more than the subtotal resection, and the quality of life was very, very, very good, independent without impairment in the majority, 94. I've done total resection in 88 of 114. On those, in spite of doing the total resection, you get 11 recurrences. So even when you do radical accession, you may get recurrence. So try and do your best to minimize the recurrences. While in the subtotal resection, which was done in 26, the recurrence was 16. More than half of it had recurrences. I had mortality in 2 cases, and I'm going to show you that. This is the man who came to us from another Arab country, a neighboring Arab country, who had a craniotomy for just puncturing of the cyst and radiotherapy, and he came my way. And of course, the answer was to go for radical accession. So he had this surgery before at another hospital in the Middle East. He came my way, and I took him for theater and I did radical accession. He saw slow deterioration and died on the 7th postoperative day. A second case who came from another Arab country with this huge tumor, and we did the surgery, radical accession, but again she died on the 18th postoperative day out of DVT causing pulmonary embolism. So if you look at the visual effect of the surgery, I got only 1 patient who got worsening of his vision. Endocrine, they all get worse and then they improve. If somebody tells you that the endocrinological picture improves with partial resection or total resection, he's lying to you. All of them, they get worse and then they gradually improve. I got 1 vascular injury of the carotid in 1 case, but he was saved. We had 2 cases who developed hydrocephalus. Look at this here. They have temporary endocrine worsening. The ones that leave with deficits is improving gradually. I'll discuss the obesity later on. Temporary DI in 100% of cases and permanent DI in 40% of cases. Temporary psychological symptoms, patients can experience seeing something like green elephants, green monkeys, and things like this, and they have seizures in some cases. Histology, we do all sorts of immune staining for our patients. and we look for beta-catenin. This is recently. And we published our data in the American Journal of Pathology. And of course, you know all about the promising targets of pharmacological treatment for craniophryngioma's dramatic response of BRAF mutant papillary craniophryngioма. Some of the cases in a hurry, as I said, they are all giants. This is a pre and post-op. Again, this man, this tumor extending from foramen of Monroe down to foramen magnum, pre-op, radical accession. This lady who came to us from another Arab country with this huge tumor, which was tackled via endoscopy. The result there, that they caused vascular injury and they caused this cavernous sinus carotid aneurysm. She was sent to us for gamma knife. Of course, we refused. We said this needs surgery, and thereby before doing surgery, we have to neutralize her aneurysm, which we did. We neutralized her aneurysm. I took her theater and totally removed her tumor and sent her back to her country. Another lady who came from Libya with this huge tumor, and again the radical accession and the follow-up. And this patient came from United Arab Emirates with this giant tumor, total removal and follow-up with no recurrence for many years. Again, this tumor from a man from Libya with this giant tumor and taking the tumor out successfully. Now, looking at the obesity issue, I told you that the obesity issue, if you find a tumor, a patient with obesity before surgery, pre-operative, then most likely this is hypothalamic involvement and you will not get any loss of weight after that. But if they develop obesity afterwards, then we'll discuss. So I looked at the obesity in my adults. None of them developed any obesity. And this is the proof. All the adults in my series did not develop any obesity. Why? I have no answer. I don't know the clue. But all the patients, adults, did not have any obesity issue. If we take the pediatric groups, let's see some of the illustrative cases. I call this Hiroshima of craniopharyngiomas. It looks like a Hiroshima bomb, a giant one in 5 months old baby. We did a radical accession for that. This, again, complex, huge tumor. Again, he came with a shunt from another Arab country, and we did the radical accession and good follow-up. Another patient who came from Iraq with this huge tumor, again extending from foramen of Monroe down to foramen magnum. I did the surgery many, many years back, and he's now a growing adult. He got into college, and he about to get married. In children, I've noticed some obesity, but my observation was that disappears in 3 to 4 years. Look at this before surgery, after surgery, got obese, and then obesity disappeared a few years back. A baby, obesity disappears gradually. From Sudan, again, obesity, and then disappears. Here, the same thing. In children, you don't say, you see obesity, but it will disappear in 3 to 4 years' time. Again, this boy from Sudan. So they have approved that obesity does not occur in adults, and it occurs in children with radical accession. Obesity is an issue. People tell you, don't do radical accession because you'll get obesity. It's not true. Some of the recurrent cases in spite of radical accession, this 3-year-old female patient with this tumor, which I excised totally, and then she came back a few years later with major recurrence in spite of radical excision. And then again, the answer to this is radical excision and a good follow-up. This boy also with this extensive complex craniophryngoma that I excised totally, and then he developed this major recurrence. So in spite of you doing the radical excision, they still have recurrences. What about if you do partial resection? They will have no doubt about that. 100%, they will get recurrence within 2 to 3 years' time. The story of my life is this boy. This is the real story of my life. 2000, I operated upon him, followed him, radical accession, no radiotherapy, no chemotherapy, nothing. Put him up through the years, all through the years, all through the years. He's now 22 or something, an adult, going into university. And when I look at him, it fills me of pride that I did his surgery without giving him radiotherapy. Again here, looking at the floor of the third ventricle, where is the hypothalamus here? This was the tumor, and we have removed it, and you can see medullary, but you can see some floor of the third ventricle, remnants of the hypothalamus. The rest has been pushed by the tumor sideways. Again, look at here and look at here. So you can do a good resection. And what I want to say, long fruitful hours, dedication, perseverance, and sacrifice of one's own time to give patients the best chance first time. When I do 10-hour surgery or 12-hour surgery or 8-hour surgery, my fellows would go to sleep. I don't, because I want to give the patient the best chance possible. In conclusion, I finished here, just a few conclusions, that you don't decide the approach unless you study the tumor, the extent of the distribution of the tumor. And again, one should not go for radical accession no matter what. I don't want to do radical accession whatever happens, because I just want to give you a good postoperative MRI. I want to give you a good postoperative MRI, and I want to give you good patients. Using microsurgery or endoscopy, just a shame. Your aim should be radical accession. You decide this intraoperatively, not before. I'm against the policy of a planned upfront limited resection. Lots of surgeons in the civilized world still say, I will go and do partial resection and give radiotherapy. This is not good. This is not convincing. This is not scientific. You decide what you are going to do inside, but you are going with the mental state of mind. I am going for radical accession. So it is your state of mind when you go to the surgery. I am going for biopsy, you will fail. I am going for radical accession, you will prevail. People would say to you, radical accession is not superior to partial resection and radiotherapy. And this is not good. This is sending the wrong message to youngsters, because what they would understand is this: do the minimum and send to radiation. Lots of young neurosurgeons would go, oh, lots of papers would say partial resection radiotherapy is the same like radical resection. It's not true. And they will go and do the wrong thing. They will do puncture of the cyst, they put a Maya reservoir, they will do partial resection and send to radiotherapy. That's why craniopharyngioma is bad in the whole world. So some people are worried about hypothalamic damage when you do radical accession. I tell them, do worry about hypothalamic damage because of your radiation, because of your frequent procedures, and because of your shunts and failed shunts and so on. For me, laminar terminalis is a very good approach to reach these tumors. Some factors favor recurrence, which we cannot change. Adamantinoma more than papillary, brain invasion. Incomplete surgical resection is a guarantee for resection, for recurrence. Giant tumors are difficult. And when you have high Ki-67, again, they have high percentage of recurrence. With this, I finish, and I thank you, and I'm ready for your questions.
Thank you very much, Professor Sbeih, for this excellent presentation and this excellent work. I agree. In French, there is an expression, on ne fait bien que ce qu'on fait souvent. This is from my Professor Sotkiewicz. We only will do what we do often. And it's very interesting to see these cases and your follow-up. I'm not surprised by the absence of obesity a long time, because I have some patients who they had obesity in this initial part, and with the years they had not obesity. So I have some question. I want to know, in your series, it seems to me that you have more pure intraventricular craniopharyngioma. It's wrong? No?
No, it's because they are so giant. I don't get the small craniopharyngiomas. I always look at them in giant size, 4, 5, 6, 7 centimeters. So they eventually will grow into the ventricle. But in spite of this, one should go for radical resection.
Yes, yes, I agree with you. Me too. I go for radical excision, but unfortunately, actually, we are obliged to have a meeting with the pediatrics, with the radiotherapist, and they are. When we operate, we are afraid about complication. But I still, when we go for operation, I go for a radical resection. So that's the idea. I don't go for biopsy or partial reduction. That's not the aim. I think it's my experience about the translaminar approach. I think when we used lateral approach for lamina terminalis with partial rejection, we had after a wrong impression for the lamina approach. I think lamina approach the best. It's subfrontal approach to be comfortable as you presented here in this study. Congratulations.
Thank you very much.
My friend. Do you have some question, please?
No, we don't have any questions.
Ah, oui. Salut Saïd, c'est Nitish, ça va?
Ça va très bien, merci. Et toi?
Oui, ça va. Hello, Professor Ibrahim Shaib. Very interesting presentation. And I would like to ask you, what recommendations would you, or advice would you give? Because in Europe, it's quite difficult because we don't get so many cases for young neurosurgeons who are starting. What piece of advice can you give from your experience and complications, cases you had from all over the Arab world for us like young neurosurgeons? What can you say?
I say the same thing like when I say about the clipping of aneurysms. You look at the aneurysm in general, people are going since the year 2000 into interventional radiology for internal embolization, coiling of the aneurysm, and people forgot about the surgery for the clipping of aneurysms. So many generations of younger neurosurgeons, they don't have any clue about what to do with the ruptured aneurysm. Although they are there, they can happen after interventional radiology, but we don't have the young generations who can clip the aneurysm. It's just the same with the craniopharyngiomas. You need to get a big number, so it is best to decide who is the surgeon to do it, because you need a very competent surgeon and you need a lot of cases to be done. So to give such cases for a certain person or persons to do the cases so that they can build up the experience. But at the same time, you should fight and you should stand against this policy of just puncturing the cyst, putting Umayya reservoir, taking a small piece and get the fluid out and everything is okay, because it's not.
Thank you very much.
We have a question from Andre.
good day. It's sorry because we have blackout. I'm from Ukraine, and dear Ibrahim, Professor Ibrahim Sbeih. So many memories from your visit in Odessa for WFS courses. I saw pictures. So thank you so much for your brilliant presentation, because we face the same problems in our Ramadanov Neurosurgery Institute when we have really our teachers that we really appreciate their work, but we have also management of our hospital that are asking us to be not very radical and just to try what you said. So I will appreciate you. I will contact you, send your presentation. I would like to present it our institution meeting, because many times we used especially shunts, partial removal, and as a first stage, and I have to say you that you have very great results of surgical treatments of craniopharyngiomas. Unfortunately, as my previous colleague said, so we don't have such experience and we don't have such results. Unfortunately, maybe 30% of our patients has really endocrinal problems, and that's why our teachers said us, please do not be so radical. So my question is, so I think that to take into account your authority as a neurosurgeon and your role in WFNS, maybe we have it is time to have some guidelines, general guidelines regarding the up-to-date treatment of pharyngiomas. But this is my questions.
Thank you, Andre. I remember my visit to Ukraine, to Odessa, with very pleasant memories. I remember the city, I remember your hospitality, I remember the streets, and I remember that you took us to attend a ballet in the big theater there, presenting that ballet dancer who died many years ago. So I have very lovely memories of the visit to Ukraine, and I hope that the war in Ukraine would finish and that you would have all the peace that you are looking for. My question is this, and the answer to your question is this. There is no way that this debate will finish. The debate will continue till 1,000 years coming. People would go for radical accession, people would go for partial accession. It is how much you believe in what you are doing. It is how to look at the literature. I would say, look at the literature. Literature has all the evidence that radical accession is better. Somebody would take one paper and say, look, this paper says partial resection is equal to a radical resection. And they teach the resident this. And the residents would say, oh, if partial resection and radiotherapy is equal to radical, why should we go for radical? So it's the bad teaching, the bad practice that has been there for so many years. It's difficult to change. It needs good guts, it needs good, strong personalities to push and say, time has changed. We are in 2022. If Yazarjil back and then the Hoffman back in 1974 did radical accession with just a CT scan, we can. The MRI can tell us the boundaries of the tumor, the situation of the arteries, the help of the anesthesia, the help of drugs. It's all there. We can do it. So it needs a big fight, and I don't see that the big fight is going to finish soon. It's going to continue.
Thank you so much, Ibrahim, and I will appreciate and send you my query to share this presentation to be sure that I will.
I think John would edit that. Isn't that John? He would edit.
Yeah, John.
And it can be then presented. Yes, John? John,
Yes.
Are you there?
Yes, I'm here.
Yeah, he was asking about the editing of this presentation. When are you going to edit it and put it on the screen so that people can look?
Yeah, thank you so much.
Yeah, it'll be on YouTube. You can get the YouTube video of what we're doing now.
Yeah, perfect. Thank you, John. Thank you for your.
Can you put your email in the chat and I'll send it specially to you, okay?
Yeah, okay, just do it. Okay. Thanks, John.
Thank you, John.
Adria?
Hello,
des questions?
Professor. Thank you very much for your excellent presentation. I just have a quick question, maybe for the younger neurosurgeons in the audience. Could you please comment on the cooperative factors that would make you perform a partial resection rather than a total resection?
Can you say the question also in French, please?
Oui, je voulais juste vous demander quels étaient les facteurs péropératoires qui vous conduisent généralement à interrompre votre résection et à effectuer une résection partielle plutôt que complète.
Right. So the question is, when can I anticipate to do partial resection or complete resection? Isn't that right? I don't decide before surgery. I study the case, I read the images, I look at the angiogram, I look at the endocrinology opinion, I sit with our endocrinologist and the therapist, this, that, and the other, and then the final decision is mine. I say we will go for total resection. And I go in, and then I find a piece of the calcification inserted in the wall of the carotid. I stop. But I'm going there for radical accession. I'm not going there to just give myself an excuse. Oh, it is attached to the carotid. Of course, all the craniophryngiomas are attached to the carotid, are attached to the optic nerve, to the chiasm, the stroke, to the hypothalamus. We know they are attached, but we are going in to try to detach these structures. So I'm going in to do radical accession. If I can, I continue. If I can't, I stop. I raise the flag of defeat and I say, I'm sorry, I cannot proceed any further. This is for the benefit of the patient. I will not continue to give you a good post-operative MRI and the patient is disabled or dead. So one should go with the mental state. I am going for radical excision. Don't decide before surgery, I am going for partial resection and radiotherapy. This is wrong attitude. You go in with the mental state of mind, with the plan, I am going for radical resection. If I can, I can. If I can't, I stop.
We have a question from Khairdin. No.
Where did you see the question?
Now that he wants to put a question, Khairdin. I don't know.
Okay, Ahmad Farzad from Afghanistan. Hello, do you have any questions? You're okay, go ahead.
Assalamu alaikum. Bonsoir. Greeting. Thank you for a nice presentation and also for a nice tour to Jordan. It was so nice and we're proud of you for your achievement, and this was great. And that's we are pleasure. It's my pleasure to have with you. And I'm from Afghanistan Neurosurgical Society, and as you know, like Ukraine, as we are in internal war along about 4 years, and we lost everything during the war, and we like to rebuild our country and also medical era and also neurosurgery as well. And we like your support as well. Thank you. Merci. Salam alaikum.
Thank you very much. I send my best regards to your colleagues. If any way or form I can help with you, please tell me. I'm happy to do it. I'm happy to support you. I'm happy to do whatever that can help you.
Okay. Okay. Thank you. Thank you. Merci.
John.
Shukran.
John, can you unmute Khairdin by yourself, please? He has a question.
No, he has to unmute himself.
He can't. He had no control.
Okay, well, I'm sorry, I can't help basic muting.
Okay. Khairdin, you can send a message, your question by
you can text the question.
Q and yeah, Q&R or on discussion.
What's the name again, Saeed?
Khairdin.
Okay, I don't see him. Simon, do you have a question?
Hello, hello.
Okay, cool.
Hello.
Hello.
Okay, nice to meet you. Simon from France. Now, I began my psychiatry since 2 weeks.
Yes.
Now, do you hear me, please?
Yes.
Yes. Yes.
Yes. I finished my neurology at Montluçon, and now I began my psychiatry at Neuilly-Plaisance, near from Paris.
Ah, yes.
I'm very glad to meet you again. My hope to do neurosurgery continue to be existent.
Could you say that in
Thank
French
you.
now, please?
Mon désir de faire la neurochirurgie est toujours persistant.
Yes. Oui, il faut persister, bien sûr. Donc,
Ouais, maintenant, j'ai fait la psychiatrie, mais quand je finis la psychiatrie, toujours est-il que je peux rentrer chez moi au Congo pour faire défendre et après commencer la neurochirurgie. Je n'ai pas arrêté de rêver neurochirurgie. Je n'ai pas arrêté.
Il faut réaliser vos rêves.
Ah oui, mais il n'y a pas de choix. Parfois, ça me saoule, mais je dois finir, quoi. Je dois finir ça.
Oui, oui.
Oui.
Non, mais c'est intéressant. Is there any question here? No.
No more question.
Hassan El Fatit, je ne sais pas s'il est là. Hassan, do you hear me?
Yes, I hear you. Yes.
Yes.
Yes, I'm here. Thank you.
Thank you to be with us. Do you have a question to our guest, Professor Sbeih?
Not specifically. I'm so glad to hear Professor Sbeih. His presentation is excellent and very, very instructive. I agree with him for the principle of gross total resection of craniopharyngioma, but the nuance is in children. In children, there are systematically a big endocrinological problem. Specifically, the problem of obesity. It is dramatic. It's not the same in the adult patient, but this is the nuance to have when we treat craniopharyngioma in children.
Right, Hassan, thank you very much for your comments. I agree with you that craniopharyngiomas in children is more difficult than adults, but again, it is a teamwork. It is not me alone. I am just part of the chain of good people, a good endocrinologist, a good radiologist, a good pathologist, and so on and so forth. So if you have a good endocrinologist, he can treat with you your patients. He will treat the endocrinological deficits. And for obesity, as I said, we have to change our minds that radical accession causes obesity. It's partial resection. It is radiotherapy, which is going to damage the hypothalamus and cause obesity. So why should radical accession be responsible while partial resection, many surgeries, radiation, shunts, infection, revisions, anesthesia does not harm the hypothalamus? We have to change the mind state and fight against this way of doing things. As I said, in my part of the world, I feel pity for any craniopharyngioma patients. If they fall into the hands of non-experienced, they would go for just partial resection. And everybody is happy. They puncture the cyst, patient may come out with better vision. You see, we have done the best for the patient. His vision has improved by puncturing the cyst. So now we'll send for radiotherapy, and then the patient is lost, like the case history that Professor Edlows put. Shunts after revisions, after craniopharyngioma accession, radiotherapy, gamma knife, cyper knife, LINAC, this and that, and the whole life of the patient and his family is destroyed.
I agree with you, Professor Sbeih. Me too. I go for a radical excision, even in pediatric population, because they are a long, like they are young, and they still with many years, with treatment, with recurrence, with hydrocephalus, with many problems. So I think I believe that radical resection, even in pediatric population, it's possible. But that's dependent of the anatomy and the extension of the tumor, like what we have in Reunion Island, because they come from countries in low-income with the long history that we have agreed to tumor, historical tumors, but we try to do total resection. Professeur Khaïdine.
Bonsoir.
Bonsoir, heureux de vous avoir avec nous.
Ah, c'est gentil, merci beaucoup. Professor Sbeih, thank you very much for your very, very nice presentation, very huge experience in the craniopharyngiomas. First comment, every surgeon, when he go to the OR, his aim, his goal, the first goal is to do the maximum. I agree with you when you go to the craniopharyngioma, is first to remove it totally. But it is not literature or some great neurosurgeon in the world who tells we have to remove. It depends to the tumor itself. It depends of the location, of the extension, of the infiltration of the hypothalamus. It depends of many, many, many things. And this is why, personally, I associate the family, the mother, and I tell them, we can do two things. We can try total excision, but we have better, more morbidity and more mortality. I associate the mother and I explain her that if you don't remove totally, we will give our life with this baby, and I have babies who are with me for 20 years with the recurrence. But before the operation, we can, on peut savoir, we can know if the hypothalamus is involved or not. And at this time, we can get this craniopharyngioma is possibly removed totally or not. And the second comment is, I think personally that for young people, the learning of the endoscopic approach, endoscopic endonasal approach is very important. And you show, for example, your first case was infrachiasmatic, and we can go through the nose. And I tell for the young neurosurgeon to learn also, we have to learn both approaches, the subfrontal and the endonasal. Thank you very much.
Thank you, Dr. Youssef. I agree with all what you said. Again, I'm not to go into the discussion whether it is the microscope is better or endoscopy is better. Strongly, personally, I believe the future is in the hands of endoscopists. Endoscopy is going to develop in the future to a large extent, and it will overcome the microscopic surgery. I encourage my young fellows and residents to go for endoscopy. So it is not a fight between microsurgery or endoscopic surgery. It is a fight for whether we should do radical excision or partial resection. And that should not be decided before surgery. If you have 9 Tesla MRI, it will not tell you what intraoperative would tell you. So don't decide, what I tell my residents, don't decide before surgery, decide inside. But you go in, I want to do radical excision. You go in and find that there is no plane of cleavage. You stop. The tumor is invading the wall of the carotid. You stop, and so on and so forth. It is teaching that the craniopharyngiomas are attached more to the carotids more than the basilar. I found one case where it is totally attached to the basilar. I could not remove it, so I stopped. So I'm not saying do radical excision come what may, whatever the result is. I say go in for radical excision, but please stop if you can't. And you cannot tell when to stop unless you are a good neurosurgeon.
Okay.
Hassan?
Professor, I would like to ask you a question about the fortuitous find of craniopharyngioma. When the patient is totally asymptomatic, even in endocrinological status and without visual trouble, when you take a decision to operate this patient?
Right. It is the same question if you have an aneurysm on angiogram, which was discovered accidentally, right? Patient had road traffic accident, you did angiogram for one reason or another, and there is a middle cerebral artery aneurysm. Would you go to clip it or not? Because this was discovered accidentally. So the same question when you have a craniopharyngioma. Craniopharyngiomas, if you look at the growth rate, they are gonna grow. And the word symptomatic is misleading because patients may have some symptoms and we say it is not a major one. No, even the mild symptoms, mild signs are indication for surgery. So even if I found incidental craniopharyngioma, I would go and treat it.
Thank you.
So we have no question, I think. And thank you so much, Professor Ibrahim Sbeih. And I hope can see you in a neurosurgical meeting, or and you are welcome to Reunion Island if you want to visit the island.
Thank you for your invitation. Thank you for all my colleagues, French-speaking colleagues. We look at the French neurosurgery with love and admiration. No one can ignore the power of neurosurgery in France. We learn from you, and we are happy to cooperate with you. I'm happy to help any of our speakers in whatever way I can. Thank you again for your invitation.
Thank you very much. Thank you very much, John.
Yeah, thank you, Saïd.
Thank you. And,
merci beaucoup, Adrian.
Merci.
Merci.
À la prochaine fois. À la prochaine fois. Prenez soin de vous.
Okay, with you.
Bye.
Thank you,
Yes.
Dr. Sbeih. See you in a couple of weeks.
Ibrahim, yes?
Okay.
Let's go and see what's the result of the match between France and Denmark.
Ah, yes, yes, we go.
Oh, it's a soccer, huh?
Okay,
United
yes,
States is
soccer.
still in there.
Okay, okay.
Okay.
Thank you very much.
Thank you.
Thank you.
Bye-bye.
Bye.